respected President of IAP Calicut, Dr. Mohandas, respected Dr. Riyaz sir, who is my teacher, mentor, and one of the persons who dragged me to pediatrics, I should say. And we are very close, close days of 1982, I believe. And even before that, he used to visit my hostel where his brother-in-law was staying next to my room, Dr. Naufal. So we had a friendship which lasts from 1980. So I'm very happy to be with him for this function. And Dr. Vijay Kumar, next year, President-elect and the Action Plan Coordinator, Dr. Ajit Kumar VT, Shija Sugunan, who is the Speaker of the Day, Narayanan, President-elect, Dr. Ajay, and all the dignitaries on the platform and the postgraduate students. I understand that coming to Department of Pediatrics, Calicut gives a lot of nostalgic feeling to me. And I understand that the department is conducting PG training sessions almost every year for several years now. And it is one of the most popular programs among postgraduates for the last several years. And I congratulate the department for this wonderful activity and also for inviting me on this occasion. I wish the very best for this program as well as the coming sessions, as it will be very useful during this COVID pandemic day. Thank you so much for inviting me.
Thank you, Raman sir. I would like to invite dear Riyaz sir for a few words. Riyaz sir.
Good evening, everybody. I would like to thank Dr. TPJ, Dr. TP Jayarama was very close to me, continues to be very close to me even now. Dr. Mohandas and Dr. Ajay and Dr. Rahul for giving the privilege to be a part of this fascinating teaching program. We all know that almost everything in the world is that stands still for the past several months, and that includes medical education. Hence, the decision of Indian Academy of Pediatrics Calicut branch to conduct this PG teaching program this year also is indeed soothing and refreshing amidst the melancholy of COVID-19. I'd like to congratulate the organizers for this program. I'm very happy that the program is being kickstarted by Dr. Shrija, who is one of the best teachers in Calicut now. I'm sure that the program will be of immense benefit to the postgraduate students, and that the program will help them to pass their tough exams, MD as well as DMD, with flying colors. I wish the program all the best, and thank you so much.
Mohandas sir, unmute. എല്ലാരും മ്യൂട്ട് ചെയ്തിട്ടുണ്ട്.
Okay. Now, thank you, Riyaz sir, for the nice words. Now I invite Dr. Vijay Kumar for felicitation.
Respected Riyaz sir, Dr. Jayaraman, IAP Kerala State President, Dr. Narayanan, immediate past President, Dr. Mohandas, the President IAP Calicut, Dr. Ajay, Secretary, Dr. Ajit Kumar, Dr. Ranjit, Dr. Nabil, and all others who are behind this another, I think, a benchmark for IAP Kerala. And last year we started our DOIN series, and it was actually a very good. Whenever we go, wherever we go in India, they know about our DOIN series. So like that, I think it will be a landmark, especially for the PG students. And if you take our DNB exams, at least 150 marks are for OSCEs. And I have seen last few years, I have seen our PG students who failed in both clinical exams just passed in DNB because of the OSCE only. So that is the importance of OSCE as far as our DNB exam is concerned. And here we are starting the program today with Dr. Shrija Sugunan, Associate Professor at Department of Pediatrics, Government Medical College, Trivandrum. And he is an eminent speaker, and we are very happy that we had a good start. We have a good start today. I wish the program all success. Thank you. JIAP. J.
Thank you, Vijay Kumar. We invite Dr. Ajit Kumar VT for felicitation.
Respected Riyaz sir, Dr. Mohandas, President IAP, Dr. Jayaraman sir, President IAP Kerala branch, Kerala, and all other dignitaries of Kerala IAP. And, dear friends, actually, first of all, let me congratulate IAP Kerala, Calicut for taking up this program once again for PGs. Last time it was a grand success, and this time too, I'm sure that it will be a great success. And what we have found that during the COVID period, the immunization has come down. But what really surprised me is that the resistance has come down also. Resistance to immunization has come down. Even though core people who are still resistant are resistant, but there's a decrease in resistance to immunization, which have over the last few years. And we know that the COVID vaccine has also a role to play in reducing the what you call drive against what you call vaccine, anti-vaccine people. So I am sure that this talk by Dr. Shrija Sugunan will go a long way improving our immunization coverage, because it is the future doctors who are listening to this talk, and I wish all the best for them for the exam, as well as all the best for the IAP Calicut. Thank you very much.
Thank you, Dr. Ajit, for the kind words. Now I invite Dr. Narayanan, who is the past president of IAP Kerala, for felicitation.
Yeah, good evening to you all. Dear presidents, Dr. Vijay Kumar is there, Dr. Jairam, Dr. Mohandas, and my dear teacher, Riyaz sir, dear friends and seniors. Yet another beautiful program from Calicut team. Every time you have been bringing out different names for the programs, and this time it is Odyssey. And it's an apt name for a PG teaching program, because the word Odyssey comes from a very difficult, long journey made by legendary Greek king Odysseus. Actually, that journey took 10 years to travel 8,000 kilometers from Crete to Ithaca. So that was his place. It's actually only some 8,000 kilometers, but it took 10 years. So that's because it was a very difficult journey where he had to meet so many adversaries, cyclops, demons, then natural calamities, then so many factors were there. So there were obstacles like our postgraduate studies. And finally, another similarity is he irritated the god of oceans. So that is Poseidon. So he was also unhappy. So we should never irritate our teachers. So that's another lesson of Odyssey. So Odyssey is a long journey. So similarity with our postgraduate years, which is very vital and very crucial in any medical professional's life. So I wish this program all success. Moreover, I am happier because this week is World International Immunization Week from 24th of April to 30th of April. This is one among the many programs IAP Kerala is organizing under the action plan, bridging the gaps in immunization. So thank you all. And I think the person who selected this name should receive a cash award from the president of IAP Calicut. Dr. Mohandas. Thank you.
Mohandas sir, mute.
Thank you, Dr. Narayanan, for introducing the word Odyssey. And definitely, this series of program is going to make your journey easier, and it definitely will not be more than what is stipulated. It won't take anywhere near.
Hello.
Net problem.
Ajay?
Hello sir, Mohandas sir, carry on.
Yes.
Okay sir. So I think we have come to the end of our inaugural sessions. I would like to thank President of IAP Kerala, Dr. T.P. Jayaraman sir, for his presidential address, and our own Dr. Riyaz sir. Sir is one of the stalwarts of teaching for pediatrics. So we'll be having subsequent sessions, maybe 1 or 2 sessions from Riyaz sir. So we are expecting a very hard-hitting batting from Riyaz sir on that. And also a session from Vijay Kumar sir and Mohandas sir. And also I would like to thank Narayana sir for giving felicitations. And Vijay Kumar sir, Ajit Kumar sir, HOD Pediatrics, Department of Pediatrics in Calicut Medical College for felicitations. And all the support sir has given for the programs of IAP Kozhikode. And also would like to thank Dr. Nabil, Dr. Sabik, and our other IAP Kozhikode PG coordinators, so who has been doing a wonderful job, and all the DNBs who are expecting her come to the meeting, and also Dr. Shija madam. So we are straight away going for the session, Shija ma'am, for the immunization session. Ma'am has recently written a very nice book on immunization. I think all the DNBs would have gone through the book once, and it is really excellent and useful for the exams as well as for general practice. And so it's a privilege to hear from immunization from Shija ma'am. So over to Shija ma'am for the immunization part. Madam, unmute it.
Ajay, screen കാണുന്നുണ്ടോ?
Yes, madam,
കാണുന്നുണ്ട്. Okay, sure. So esteemed dignitaries and dear friends, good evening, everyone. First of all, I'm extremely thankful for the IAP Calicut team led by Mohandas sir and Ajay for giving me this opportunity. So I think I would just go straight to the topic. And as you all know, it wouldn't be possible to cover everything in immunization. My idea today is to give you a brief overview, which would help you know how to approach an OSCE question. So as the first slide itself shows you, we are in the midst of the national or the World Immunization Week, and this year's slogan is "Vaccines Bring Us Closer." So we start. So what is the plan? We are going to discuss a bit of principles of vaccination, national immunization schedule, something, and we'll be discussing in between some recent changes in IAP schedule and some clinical dilemmas. So we start with the vaccine, which seems to always occupy your news, that is the polio vaccine. So what is new in polio vaccine is that now the IAP has come with a newer recommendation that we need to continue with the birth dose of OPV, followed by IPV at 6, 10, and 14 weeks. That means they have done away with IPV and OPV at 6, 10, 14 weeks. They're now recommending only IPV at 6, 10, and 14 weeks. They have also recommended an additional IPV booster at 5 years. So that is something new. So now the questions are, why OPV at birth? We know that naturally they have done away with OPV at 6, 10, 14 weeks, probably thinking about the complications of OPV, namely VAP and VDPV. So why is it that we are still continuing with OPV at birth? Second question, what impact did withdrawal of trivalent OPV have on global polio eradication? Right to strategies to prevent VDPV, and what is the difference between VAP and VDPV? So why is OPV being given at birth? you're giving OPV at a time when the baby is still protected by the maternal antibodies, so the risk of VAP is negligible. And OPV 0 dose acts as a priming dose. That means that after a baby who has received a OPV birth dose will have a better seroconversion rate to all the 3 serotypes than a baby who has not received OPV. And most importantly, OPV priming dose is associated with a better mucosal immunity with future IPV doses. So that is very, very important, because one place where IPV lags behind OPV is that the mucosal immunity, especially the gut mucosal immunity provided by IPV, is significantly lower than OPV. And that is also the reason what happened once we withdrew the type 2 from the trivalent OPV. You can see in 2016, we had a very low incidence, and by 2020, we had a very high incidence of VDPV. In 2016, only 3 countries were reporting VDPV. Now 24 countries had reported VDPV. There were only 5 cases of VDPV in 2016, and now we have more than 800 cases of VDPV. So that shows you the importance of mucosal immunity. So why did I show this? For you to understand what exactly VDPV is when you're giving oral polio vaccine. If the community immunity is low, then you will have many susceptible people in the community, which will enable the virus to get transmitted from one person to another. As the virus goes on getting transmitted, maybe for 6 months or more or 1 year, the virus regains its neurovirulence and causes paralysis. So you should know that the nucleotide substitutions happen at a rate of 1.1% per year. And for a type 2 VDPV, only 0.6% divergence is enough. That means if a polio virus remains in circulation for 6 months, then the VDPV can be created. So there's 2 things that you have to understand. One is, you give a polio vaccine today, tomorrow you're not expecting a VDPV. The VDPV will happen only when the genetic mutations have occurred. And unfortunately, once it is formed, it can remain in circulation for years. So for VDPV prevention, what we have to do, so unfortunately, OPV is causing VDPV, and somehow OPV seems to be preventing VDPV also, but that's not the answer. The answer is strengthened routine immunization. That should be the first answer. And also use of IPV, because the commonest cause of VDPV continues to be type 2, and type 2 is present only in IPV. So every child should receive an IPV. The newer IAP guidelines also say that once you have completed the primary series of polio vaccine, if from the government sector, where fractional dose of IPV is given at 6 weeks and 14 weeks, you can offer the child 1 extra dose of IM IPV, because you're looking at the type 2 protection too much. And another new point that you have to notice is that WHO will be shortly launching NOPV2. NOPV2 is novel OPV2, which is supposed to be more genetically stable, so less chance of reversion or creation of VDPV. So we are looking forward to introduction of NOPV2 to counter VDPV outbreaks, so that, and finally, naturally, your aim is to phase out OPV. So that will only happen if we get rid of both the wild polio virus as well as the VDPVs. And what is the difference between a VAP and a VDPV? A VDPV is a virus which has regained its transmissibility and neurovirulence. VAP is a virus which has regained its neurovirulence. It is not transmissible. So you do not have VAP virus transmitting in your community. It is the VDPV that transmits in the community. So VDPV can cause outbreaks. VAP cannot cause outbreaks. VDPV is of 3 types: the immunodeficiency VDPV, circulating VDPV, and ambiguous VDPV. Whereas VAP, there is only 2 types. That is a contact VAP or a recipient VAP. VAP, you should know, is commonly seen when a patient is immunodeficient and the polio virus keeps on multiplying in the gut and getting excreted for the long time. So it gets time to get mutated. So that is also a mutated virus. And the most common type of VDPV is type 2. 97% of VDPV is type 2, whereas 40% is type 2 in VAP, and the most common is type 3. So that says the difference between VAP and VDPV. Now moving on to a common scenario that you must have come across many times, that is a 6-month-old child brought with accidental detection of a swelling in the left axilla. Most probable diagnosis, you all know, it's a BCG adenitis, and you all know the treatment. And what physical examination findings would you specifically look for and why? So that is a question here. So you know the treatment is wait and watch, no role for antituberculous treatment, no role for antibiotics. If the BCG node is fluctuant, you can aspirate, and if it is too big and causing problems, you can go for excision. So instead of that photograph, which I had put for the initial question, if this is the photograph that has been put, and would your answer remain the same? So that comes to the last question. That is, what are the things that you need to look when you are dealing with a child with suspected BCG adenitis? It's important to understand that you call as a BCG adenitis mild when only the regional, that specific regional lymph node is enlarged. You call it moderate when you're seeing a sinus, and you call it severe when you have evidence of dissemination in the form of, or severity, like an osteitis, osteomyelitis, disseminated BCGiosis. So as you can see here, it is a sinus formation is there. You have multiple lymph nodes getting involved. So this is a child. So it is important that you should look for lymph node enlargement in the other sites. You would look for hepatosplenomegaly, failure to thrive, consanguinity, because these are all pointers of immunodeficiency. So a bad or a severe BCG adenitis or BCGiosis, you should rule out immunodeficiency, which may be primary or secondary. Specifically think of Mendelian susceptibility to Mycobacterium tuberculosis. That has also been described very commonly lately. So that is the answer for the last question. So from there, we have not yet left the BCG. A 4-month-old Rahul is brought with no BCG scar. What would you do? The first answer is, you at 4 months, you should not be declaring a child absent BCG scar. BCG scar in some children may take time to form. It is only after 6 months we say whether the scar is present or not. Now, what does a BCG scar mean? BCG scar does not mean that you're protected against tuberculosis. And absence of BCG scar does not mean that you are not protected against tuberculosis. So what does it mean? It means it is an evidence that you have received the vaccine. So it's just an epidemiological factor that you're having a scar there. Till what age can BCG be given? According to IAP, it can be given up to 5 years of age. According to the National Immunization Schedule, it can be given up to only 1 year of age. So why is this upper age limit? Is tuberculosis not common in adults and adolescents? Definitely, it is very common in adults, adolescents, and older age group. So BCG is recommended only up to 1 year or 5 years, because you're assuming that India being endemic for tuberculosis, patients would be already exposed to tuberculosis. And once you are exposed to tuberculosis and have a latent TB, you in fact are to some extent protected from serious forms of disease. In fact, if a patient has a latent tuberculosis and he has a reinfection, the chance of him getting a progressive tuberculosis is 79% less. So that is the reason why it is not recommended beyond 5 years or beyond 1 year. What if there is no scar? There's absolutely nothing for you to do if there is no scar, because then you might not have scar if you landed up giving the vaccine subcutaneously, or something wrong with the vaccine, or you don't have the leukocyte migration inhibiting factor. There are multiple reasons why you do not have a scar. So if the baby has a documented evidence of receiving the BCG, you don't have to do anything. If there is a doubt whether the baby has received the vaccine or not, or they do not have the card, it's only a verbal this thing that it has not been received, and the baby is more than 6 months of age, you can repeat BCG once. So if there's a documented evidence, no need to repeat. If there is no documented evidence, a single repeat may be given. Now, what is trained immunity? Now, this has importance now, because it is a terminology that has been there for quite some time, but it is something that we are listening more frequently now, because it is because of this that now the interest in BCG and the COVID disease came, and because of which there are some studies which are being done by the ICMR on this. So what exactly is trained immunity? When you have a primary infection or a vaccination, we all know the cells of innate immune response, like your macrophages, natural killer cells, get stimulated. And these stimulated cells of innate cells, they go epigenetic reprogramming. And because of that, when you have in future infection with a different organism, these innate cells respond better. So I hope it's clear. When we are talking about vaccination, what you normally talk about is adaptive immune response, where it is the secondary cells, your T lymphocytes, B lymphocytes, which play a role. Here, we are talking about trained immunity, where it is the primary immune cells, that is the initial innate response cells, which are getting trained. And instead of giving a homologous protection, that is, instead of protecting you against the same disease for which the vaccine has been given, it is protecting you against another disease. So multiple studies have proven that BCG has non-specific effects. The non-specific effects include heterologous protection against respiratory infections, sepsis caused by viruses, Shigella, protozoa, as well as 48% reduction in neonatal mortality in low birth weight babies. So that's a new question that would come up in BCG vaccine. Now, this we have already discussed about the scar, but what you need to understand is that non-specific effects, that is the trained immunity, is better in patients who have the scar than who do not have the scar. So revaccination leads to little or no extra protection against tuberculosis. So it is not recommended, but in fact, it may increase the non-specific effects. So that is also a new information, that the non-specific effects are seen more in patients who have the scar. So moving on to the last question, that is the new BCG vaccine in phase 3 trial. Now, why did I put up this question? This question is important for us because one, it is a phase 3 trial. Second, the newer BCG vaccines that we are discussing are already undergoing phase 3 trial in India itself, and it has been approved by the ICMR to conduct the studies, especially the VM1002 and the MIP. And VPM 1002 is in fact licensed by Serum Institute, and MIP is produced by Kerala. So India has a role there, and the studies are being done in India. So you need to know that. And we also need to understand that MIP and Mycobacterium vaccae they are immunotherapeutic vaccines. So that is also a new term. You can have a question, what is an immunotherapeutic vaccine? So the newer vaccines in BCG, you are looking at BCG vaccine to prevent diseases in unexposed people. You're looking at BCG vaccine to prevent and previously exposed, that is a contacts you're trying to prevent, and also long-term effect. And also you're looking at the immunotherapeutic benefits for the vaccine. So these two vaccines, it has been found that when they are administered to patients who are already taking anti-tuberculous treatment, the sputum negativity happens earlier. That means your macrophages are acting better as your innate immune system and adaptive immune system becomes active following vaccination. So it has not only a preventive action, but it is also immunotherapeutic. So from there, we move on to, still we are stuck at the birth, and we move on to a 1.5 kg baby born to hepatitis B positive mother. So the questions are, write the interventions you would do to prevent infection in the baby. What would you do if the parents cannot afford immunoglobulin? How would you follow up the baby? And if the antenatally the mother has a high DNA load, what additional measure will you advise? So write the intervention you would do to prevent infection in the baby. If this baby was more than 2 kilograms, you have no doubt you want to give the vaccine at birth and immunoglobulin at birth, and continue with 2 more doses at 1 month and 6 months. That is 0, 1, 6 of hepatitis B vaccine. But our baby is unfortunately less than 2 kg, but its mother is HBsAg positive. So again, at birth, you will give the hepatitis B immunoglobulin and hepatitis B vaccine, but you have to ensure that you are giving 3 more doses of hepatitis B vaccine. That is at 1 month, 2 months, and 6 months. So again, what you have to note here is that why I have opted here for the 0-1-6 schedule rather than what we are following at 0-1-2-3 schedule. The reason is all the 3 schedules give you more than 90% seroconversion rates, but it is the 0-1-6 schedule which gives you the highest GMTs or highest antibody titers. And here you are combining a vaccine with an antibody, hepatitis B immunoglobulin. So your vaccine is the one which is going to give you a long-term protection. And for that, your vaccine has to be administered at a time when the immunoglobulin effect is less, so that it does not interfere with the immune response of the vaccine. That is why you will find that the guidelines when it comes to hepatitis B positive mother, they want you to give the vaccine at 0, 1 month and 6 month interval. Now, coming to what would you do if the parents can't afford immunoglobulin? Continue with vaccination. Here you would like to give an extra dose. That is, even if it's a term baby more than 2 kg, you would like to give 0, 1, 2, followed by a 4th dose at 12 months of age. Remember, vaccination alone can give you 75% protection. Hepatitis B immunoglobulin and hepatitis B vaccine together gives you 95% protection. So this is also very important to understand, and it is also important for us to understand that this 5% who are not protected when you're combining hepatitis B immunoglobulin and hepatitis B vaccine are the ones where the mother is having a high viral load. So that is why the last question came as what to do if the mother's viral load is high and you know about it, then what extra measure can you do to see that even that 5% unprotected by a vaccine immunoglobulin combination can be given an extra protection. So here you can start tenofovir at 28 to 32 weeks. You can continue till birth or 3 months after delivery. Along with that, definitely combine your hepatitis B immunoglobulin and hepatitis B vaccine. Recently, a question had arisen that a baby was born at a local hospital. The baby had received the vaccine, and 2 days after the receipt of the vaccine, it was informed that the mother is HBsAg positive. In that scenario also, you can give hepatitis B immunoglobulin up to 1 week of age. So with that, we move on to the next question, that is, how would you follow up the baby? So at 9 months, you have 3 different jobs to do. You have to rule out the infection, you have to confirm protection, and if not protected, you have to do the necessary. So how do you rule out infection? Check HBsAg. Remember, you don't check anti-HBc in a baby born to an HBsAg positive mother because it can remain positive with the baby for a long time, being an antibody which is supposed to be interfering with estimation. So you don't look that. You only look for HBsAg and to rule out infection. And to confirm protection, you need to check the anti-HBsAg. And if you find that the anti-HBsAg titers are low, go ahead and revaccinate with 3 more doses. So that is what you are expected to do at 9 to 18 month follow-up. And you cannot, if someone asks, can you do the follow-up before 9 months of age? No, you cannot do the follow-up before 9 months of age because you want the effect of the hepatitis B immunoglobulin that you have given at birth to completely wane off. So you have to wait till 9 months of age. Now moving on to something, so we have moved away from the birth, and just one thing more. Remember that if a question comes on a preterm vaccination, every vaccine that is recommended for an older child needs to be given to a preterm child. So there is nothing difference between vaccination schedule for preterms and term baby. It remains the same. And one more word, why is the hepatitis B vaccine cut off at 2 kg is there? That is because if a baby less than 2 kg is administered a hepatitis B vaccine at birth, around 68% of them will seroconvert. But the same baby, if they have given hepatitis B vaccine at 1 month of age, more than 90% will seroconvert. So seroconversion for babies less than 2 kg is better at 1 month than at birth. That is the reason why we used to recommend that less than 2 kg baby needs start vaccination either when they are 1 month of age or when they are more than 2 kg. But also remember that the immunization schedule that we currently practice in India, whether it is the NIS or whether it is the IAP schedule, you have a birth dose followed by 6 weeks, 10 weeks, 14 weeks. So you are anyway giving 4 doses. So in fact, you can give all babies universal hepatitis B vaccination at birth. Now moving on to the next one, it's a 45-day-old baby who developed a seizure 24 hours after DPT. On examination, child is febrile and irritable with AF bulging and relatively stable vitals. And for the AF bulging, you have taken a CT scan and you can see what it is showing. It is showing a hemorrhage. So write the type of AEFI and what is your advice for further DPT vaccination. So a fever following a DPT vaccination is a vaccine product related AEFI. A seizure following a DPT is also a vaccine product related. A vaccine quality would be somebody developing a paralysis because a partially inactivated IPV. That is a vaccine quality related problem. If you develop an injection abscess, it is an immunization error. If the patient collapses by seeing the injection, which usually happens in the adolescents, it is an anxiety related reaction. And if it doesn't fit into all these four, it lands up being a coincidental. So here, even though it is fever and seizure, because you are provided with an image there of an IC bleed, you should know that this AEFI, in fact, is coincidental. So now the question was, what is your future vaccination advice? Do you want to continue with whole cell or SLLR pertussis? Since this is a coincidental AFI, you can give either whole cell or SLLR pertussis. Now, a word about seizures, DWPT and DAPT. You should know that seizures per se are precautions and not contraindications for DPT. There are only two absolute contraindications for DPT, and that is anaphylaxis to a previous dose of DPT or encephalopathy within 7 days to previous dose of DPT. Progressive neurological disease is no more a contraindication, that is a precaution. You need to remember what is a contraindication for whole cell pertussis is also a contraindication for SLLR pertussis. But whenever a patient develops fever following a DPT, it is important to rule out progressive neurological disease. But as I said already, it is a precaution and not a contraindication. Earlier, it used to be listed under contraindication. So what does that mean? When you have a patient with a progressive neurological disease, that is someone who has showing developmental regression, you have to wait till the diagnosis is confirmed, the prognosis explained, and the treatment plan charted. So that you can tell the parent that what the progression of the disease is not due to the vaccine, but due to the disease. So that is why you don't want the vaccine to be blamed for anything bad happening to the baby. That is why first confirm the diagnosis, establish the treatment, counsel the parents, and you can continue with DPT. And another one more word regarding seizures and DPT, we also need to understand that the risk of seizure per se is significantly lower with DAPT, roughly around 0.6% compared to 6% with whole cell pertussis. So definitely there is a lower risk with SLLR pertussis, mainly because SLLR pertussis causes less fever. If someone asks you what is the vaccine that you can give after fever and seizure, for a common febrile seizure, your answer should be he can receive either whole cell pertussis or SLLR pertussis, but risk of seizure will be less with SLLR pertussis. Now, you should also know that SLLR pertussis is not superior to whole cell pertussis. It has got limited efficacy on infection and transmission. That means when you have taken the vaccine, you may be protected with the disease, but the bacteria can multiply and you can act as a carrier of disease for another person. So it does not decrease infection and transmission. It just decreases the disease, and the immunity wanes before 6 years of age. So that is also important. The SLLR pertussis weaning happens earlier, and that is why in the West, they are finding a resurgence of pertussis cases. And that is also the reason every day you find a new guideline telling that Tdap vaccines can be repeated again and again. And hope now you understand that earlier Tdap vaccine was recommended only once in a lifetime, and now it is recommended that any place when you're taking TD, you can take Tdap if you want. If you want, that is not mandatory. But regarding pregnancy, every pregnant lady during each pregnancy is recommended to be taken Tdap. That's especially to prevent infant pertussis, because infant pertussis has the highest mortality compared to pertussis happening in older age group. So with that, we move on to a next AFI, and 18 hours after MR vaccine at 9 months of age, baby developed fever with seizure. The development of the baby till now is normal. There is a history of febrile seizure in sibling. Again, the question is, what type of AFI is this? What would be your advice regarding 18 months second dose of measles containing vaccine? Which vaccine combinations are associated with increased risk of febrile seizures? Now, what is the type of AFI here? You need to know that This again is not a vaccine product related AEFI because febrile seizures happening following MMR or MMRV happens only after 5 days. That is, you're expecting the seizure to happen when the vaccine virus has multiplied in your body and is mimicking a natural infection. So fever following a measles containing vaccine ideally happens only after 5 days. Any fever happening before 5 days is not related to the vaccine, but a coincidental fever. Whereas killed vaccines cause fever within 48 hours. So a febrile seizure following a killed vaccine happens within 48 hours, whereas a febrile seizure following a live vaccine happens only after 5 days. So here again, it is not a vaccine product related AEFI. It is a vaccine. It is a coincidental AEFI. And which are the vaccine combinations which are associated with increased risk of febrile seizure? MMR and varicella, when given separately on the same day, the chance of febrile seizure is less compared to MMRV vaccine, where you have all the 4 components together. And one of the reasons why they don't recommend it below 2 years because of the risk of febrile seizure. And you should also know that when inactivated influenza vaccine is combined on the same day, given on the same day along with PCV13 or DTAP, it has been found to have an increased risk of febrile seizure, but that is not considered as a contraindication or precaution. It's just for you to know. Now, moving on to another case. So looking at the photograph, you know what you're looking at. It is a child with conjunctival hemorrhage, and in this COVID season, almost 30% of patients in South India, we are definitely seeing conjunctival hemorrhage. So as you can see here, 10-year-old child coming with fever and seizure. Total count is 10,000 with the polio predominance. ESR is only 20 with CRP very high. The routine PUO workup, that is lepto PCR, is negative. Usually conjunctival hemorrhage, you think of lepto, and that is negative, and the COVID antibody is positive. So most probable diagnosis here naturally is MISC, and the preferred treatment is definitely IVIG. Now, the question is not that. The question is, this child had an intrafamilial contact with chickenpox, because of which the child had received post-exposure prophylaxis with varicella vaccine. We all know post-exposure prophylaxis can be given up to 5 days after vaccine administration. So she had received the varicella vaccine 1 week back, and now she has come with a disease which requires a high dose of immunoglobulin. So now what is your advice regarding further vaccination for this child? You need to understand that when you're giving a live vaccine, it does not cause an immediate response. The live vaccines, just like viruses, multiply in your body, then it enters the cell, and then it causes multiplies, and then it causes an immune response. There is always a time for that. Time for the virus to enter the cell, time for the virus to multiply, and then elicit an immune response. And this usually takes a minimum of 2 weeks' time. So while your virus is trying to enter the cell, if you are going to give a high dose antibody, the antibody will neutralize the virus and will not allow it to enter the cell and cause a disease. So a live vaccine, which is administered within 2 weeks of the antibody containing product, is considered invalid and needs to be received and needs to be repeated after the recommended interval. So for this child, she will require 2 doses of varicella vaccine in the future. What she has taken now is invalid. Now, when should she take the vaccine? Because it is a high dose immunoglobulin that you have given, she has to take the varicella vaccine 11 months later. What about the TD or the Tdap she is due? She can take it on schedule. So the interval recommendation is mainly for killed vaccines, mainly for live vaccine and not for killed vaccine. And the interval depends upon the quantity of antibody present in the antibody containing product that you are giving to the child. So even though there are so many things written here, but most probably the question that you will be asked will be related to IVIG and not to the other things. So now moving on to the next question. This is a 5-year-old child who had a class 3 dog bite. Child was given TD as well as anti-rabies vaccine IM on day 0. And on day 3, the child was brought for the second dose. So write the further immunization schedule for this child. What would you do if the child gives history of a complete post-exposure prophylaxis 2 months back? What are different types of rabies monoclonal antibodies available, their limitations and advantages? Write the current WHO anti-rabies immunization schedule. So moving on to write the further immunization schedule for this child. So what is the issue you are facing here? It is a category 3 bite. Unfortunately, the child has not received rabies immunoglobulin and he is coming to you on day 3. So you would have ideally given the rabies immunoglobulin on day 0 and he is coming to you on day 3. The solution is you can give the rabies immunoglobulin now. Remember, do not give rabies immunoglobulin if the child had come to you after day 7 of vaccination. Because as we discussed in the hepatitis B case, when you give an immunoglobulin after 7 days, the immunoglobulin will interfere with the response the vaccine is going to cause. So best is give it along with the vaccine. And if you're not given along with the vaccine, maximum you can wait up to 7 days. And naturally continue with the further doses. Now, what would you do if the child gives history of a complete post-exposure prophylaxis 2 months back? This is very common. If you have a pet at home, they'll come first with a class 2, then with a class 3, all that things happen because they play with the pets and they get small injuries in between. So there is no vaccination if re-exposure occurs within 3 months of the last complete pre or post-exposure vaccination. Now, what is new in rabies vaccination? Just like ISRO comes up with a new rocket every time, our vaccination companies also come up with new vaccines. If not new vaccines, they definitely come out with a new combination to make your life a little more miserable. So now you have, fortunately, a monoclonal antibody, which doesn't make your life miserable, but that is supposed to be better than what you were giving till now. So what is the advantage of the monoclonal antibodies? Its main is consistency. When you're preparing an immunoglobulin, either through the horse or through the human, what you don't have, you cannot be always say that the amount of immunoglobulin, the antibody is always consistent. It can be variability. But since this is produced in the factory, it's a consistent quantity of antibody will be there. More rapid production capability. So you can produce large number of monoclonal antibodies in a very short time or with the factories. And there is, of course, no risk for blood-borne pathogen transmission. So that is also important. So now the IAP recommends rabies monoclonal antibodies in superior to the anti-rabies immunoglobulin that we were using before. Right now in India, you have 2 types of monoclonal rabies antibody. One is the human monoclonal rabies antibody, and the other is a cocktail of 2 murine antibodies. Now, the advantage of the cocktail is it binds to different sites on the rabies glycoprotein. And when it is binding on different sites, what it advantage is that there is a mutant strain of rabies, which is usually seen in bats, and there it is found to be effective. But as far as India is considered, bat rabies is not there in India. So for us, either of the antibody products are equally efficacious. And you should also know that many other monoclonal antibodies are in the pipeline in different stages of development and trials. So the new immunization schedule, which is endorsed by IAP, which is not yet endorsed by DGCI. What does that mean? That means for office practice, if a patient comes to you, you still need to follow the old schedule because DGCI has not yet approved it. But WHO has approved it and IAP also stands by the WHO schedule. Now, what is it? Or what they have done is that they have just removed 1 dose from both the pre and the post-exposure schedules. So the earlier the post-exposure schedule, you needed to take 5 doses. That is 1 dose at day 14 as well as 1 dose as day 28. Now they have reduced it to 4 doses. That is the 4th dose can be taken anywhere between 14 and 28. Similarly, for ID, you needed 4 doses and now you need only 3 doses. So earlier you had 0, 3, 7, and 28. Now the day 28 dose is not there. In pre-exposure prophylaxis, we used to take day 0, day 7, and day 28. So now the day 28 schedule is not there. Regarding re-exposure, that is when you have completed a previous pre or post-exposure and then again you have re-exposure, the schedule remains the same, that is 0 and 3. Another thing to note is that in re-exposures, intradermal schedule, you have only 1 site intradermal dose, whereas in other schedules, you have 2 site intradermal vaccination. So So now moving on to the next case, that the penultimate case, that is a 12-year-old child with medically non-responsive ITP. That means you would have by that time given your thrombopoietin receptor agonist and newer ones also. And the child also gives history of a significant bleed recently. So naturally you have to do something more. So what other treatment options do we have? So if you have exhausted all your medically available resources, including rituximab, probably the next option you have is splenectomy. Are any vaccines contraindicated post-procedure? Absolutely not. In fact, routine vaccinations are not contraindicated. The only small exception would be live attenuated influenza vaccine is not recommended in patients with splenectomy. You want to give them a killed vaccine. Otherwise, all other routine vaccines can be given normally. How will you plan immunization in this child? Which killed vaccines are not recommended to be administered on the same day and why? So how would you plan? So this child is definitely at a risk of having infections with capsulated organisms. So you need to give him especially hip, pneumococcal, meningococcal vaccines. Along with that, you can give an yearly influenza vaccine. In a country like India, definitely typhoid conjugate vaccine can also be given. All other live and killed routine vaccines must be offered to the child. And if the question instead of vaccination is just prophylaxis, remember you have to write penicillin antibiotic prophylaxis that needs to be continued along with the vaccine. So that is one point that you should not forget if the question is on splenectomy. And you should not combine PCV13 with Menactra because that is conjugated with diphtheria toxoid and it is found to decrease the seroconversion rates of some of the serotypes in PCV13. Whereas Menveo, that is the MCV CRM, does not interfere with PCV13 seroconversion rates or antibody titers, so it can be given along with it. So what you have to know, if you are prescribing Menactra, you have to give PCV first and then give the meningococcal conjugate vaccine 1 month later. If you are prescribing both Menveo and PCV, you can give these vaccines on the same day. So here the child requires a pneumococcal conjugate vaccine, followed 8 weeks later by a pneumococcal polysaccharide vaccine. He also needs 2 doses of meningococcal conjugate vaccine and yearly influenza. He requires a single dose if he's not previously vaccinated. He's previously vaccinated, he doesn't require. And definitely you can also offer a single dose of typhoid conjugate vaccine. So from there, we move on to the last case. That is a 10-year-old child with acute lymphatic leukemia is admitted with disseminated varicella syndrome. How could you have prevented this? Write the immunization recommendation for patients on chemotherapy. So you should know that in case when you talk about disseminated varicella syndrome, it is in fact a very high disease with a very high mortality. You can see the number of vesicles the child is having, which itself is proven a proof that how severe the disease was. Usually they will present with shock, with coagulopathies, with multi-organ failure, and the mortality rate is high. So how would you prevent this child? So you have 2 jobs. So when the question is how could you have prevented this in this child, you have to prevent following an exposure. You have to prevent an exposure on one side and you have to take certain actions post-exposure. So how can you prevent an exposure? That is immunize the close contacts with varicella vaccine. Remember, 80 to 90% of varicella infections in a child on chemotherapy often happens. The source of infection is a household contact. So it is important that they get vaccinated. And remember, once they get vaccinated, they don't have to keep a distance with the child. It's not considered transmissible unless the patient post-vaccination develops vesicles. If they develop vesicle, they should not come in contact with the patient. Otherwise, no problem. So you should recommend MMR and varicella vaccine for household contacts of patients on chemotherapy. What about post-exposure? So if the child, somebody in the family has already had the chickenpox, you can offer varicella zoster immunoglobulin. Again, you should know it's not currently available in India. So the other option you have is IVIG 400 mg per kg. On a practical note, it is not completely preventable when you're giving IVIG because the amount of anti-varicella antibody that is there in IVIG is not predictable. because you are taking a pooled immunoglobulin. So in the population from where you have taken the pooled immunoglobulin, if they have enough antibodies against varicella, your patient will be protected. But still, that is one thing that you can offer the child. And if that is unaffordable, you can also offer acyclovir 80 mg per kg per day, starting from day 7 for 7 to 10 days. Again, a word of caution here. Acyclovir starting from day 7 for a child who is on chemotherapy has not been found to be effective. And another reason for that is acyclovir has a very poor oral bioavailability. So again, on a practical note, valacyclovir may be a better option, but if the question comes, this is the one that you are expected to write. And it's also, we need to suspend chemotherapy for 21 days. That is the incubation period of varicella disease. If you have seen varicella infection in patients on chemotherapy, you will know how devastating it is. So because of the disease per se and the secondary infections they end up having. So what are the recommendations? Avoid live vaccines during chemotherapy. Usually we recommend vaccination 3 months after chemotherapy. The newer IAP guidelines recommend vaccination 6 months after chemotherapy, that is live vaccine. Any killed vaccine that is given during chemo needs to be repeated later. So that is also very important. So which is the killed vaccine that is recommended during chemotherapy? That is influenza vaccine. And that has to be taken either between chemo cycles or 2 weeks before the next chemotherapy happens. You should also know that if for any reason, the question is, how would you plan vaccination for a child you are going to put on immunosuppressive? If you have enough interval, then a live vaccine should be given only 1 month before the start of chemo, and killed vaccines can be given up to 2 weeks before the start of chemo. So like you have taken a biopsy and you're waiting for the results to come. That is what you can offer if you think that you are going to have this interval. Now, vaccinate, as we already discussed, it's important to vaccinate contacts with varicella as well as MMR. Then booster doses of childhood vaccines may be offered after 6 months of stopping chemotherapy. That means a child who has previously received all the vaccines, it's applicable especially for acute lymphatic leukemia. Once you have stopped the chemo, you can give single booster doses of most of the childhood vaccines that the child has already received. So these are the recommendations for children on chemotherapy. So with that, we conclude with some points to remember. Remember, when you are handling an OSCE, read the question very carefully. First of all, when you're given a scenario, identify the issues first. As we saw in many conditions, when you just read, you may be writing only part of it. When you really look into it, you realize that it has 2 issues. Prevention, you have to primary prevention and secondary prevention you have to look for. And answer to the point. Remember, the question marks is for the points. Your essays written there or your words written there are not going to fetch you the mark. So always answer to the point and keep an eye on the marks allotted. The marks will tell you how important your answer is or what are the number of points probably they are anticipating from the answer, the indirect way of guessing that. And also again telling you this discussion was just an outline, not a comprehensive one. We have not covered so many things. We have not covered the principles, the routine principles of vaccination regarding vaccine spaces. We have not discussed about the recent changes in the national immunization schedule, especially PCV, which has introduced in a different schedule than what the IAP is recommending. We have not discussed about the Mission Indradhanush, the newer form of it. So all those parts we need to read it up. So this was just giving you a stimulant for you to read further on immunization. So before concluding, we are in the midst of a pandemic and the COVID shark is really finding to be ferocious. We just hope that mass vaccination with herd immunity, we will be able to dodge the COVID. Thank you. So I would be definitely willing to take up questions, if any.
Dr. Shrija, there are a few questions in the chat box. You are muted. Please unmute.
Okay, sure. So I read the first question, that is from Dr. Nisha Krishnan. Since we are giving only bivalent OPB, how can type to VAP occur? Okay, very good question, but you need to understand, as I already said, the VAP, it's not exactly VAP that is occurring, it is VDPV that is occurring here. And VAP data, we don't have that much. That also you should know. What is there in the public domain is mainly the VDPV data and not the VAP data. I hope the question is on VDPV. That is happening because of the OPV that you had given previously, or because of the OPV that you're currently giving to tackle the VDPV outbreaks. So, and we also said that from a oral polio vaccine, VDPV to develop will take 6 months to 1 year. And once the vaccine has mutated and gains the ability of transmissibility and neurovirulence, it just acts as a wild polio virus. And as long as you have the susceptible population, it can circulate for a long time. We were expecting the VDPVs to die off soon, and that was one of the reasons why we had taken away the type 2, but unfortunately it is lasting. Next question is, because of non-specific effects of BCG vaccine, does that mean if no scar, BCG has to be repeated? So here again, we are repeating that BCG's non-specific effects have been shown. Right now, we are not advocating BCG for its non-specific effects. So that was just an information for you. So, and now you have a COVID vaccine to prevent COVID. So why do we want to go after the BCG vaccine to prevent COVID? So that is definitely not an indication to repeat BCG. BCG is being taken definitely for prevention of tuberculosis. So absence of scar should not be any non-specific effect should not be an indication to repeat the BCG vaccine as of now. In case of 016 schedule for hepatitis B, instead of Pentavac, will we go for DPT or will we go for Penta at 1 and 6 months? I would say you would give Penta at 1 month, and then in the government schedule, you don't have, in fact, any other option. You have to go for 0, 1, 2, 3 because that is what is available. And in an otherwise schedule, definitely you can give the Pentavac at 6 weeks, but you can go for the Quadravac may be given for the 10 and 14, and then give at 6 months the standalone hepatitis B vaccine. So if you're giving Pentavac itself, I would say that later you can give a hepatitis B vaccine, especially if you find that the anti-HBsAg titers are low. If a child presents with a missed second dose, should we repeat the entire dose? Okay, Parvati, that's a good question. So we need to know that when you are giving a vaccine, the memory cells are being formed. And these memory cells are there. They are not going anywhere. So you don't have to repeat the vaccination schedule. You just have to restart from where stopped. So imagine you have a child who has taken your DPT vaccine at 6 weeks. He comes to you at 6 years of age. So you would still consider that the patient has taken the first dose of DPT. So you would give 2 other doses of DPT followed by the booster 6 months later. So you need to start from where you have stopped. So the only very few exceptions where you restart the vaccination, one of them would be the hip vaccine. If the patient has received a hip vaccine and the patient develops a hip meningitis, you need to repeat the hip series. All the 3 doses need to be given. And another thing, since I've touched upon the question of hip, you should know that if a hip is a highly effective vaccine, so if a baby develops a hip meningitis, even after 2 or 3 doses of hip vaccine, the baby needs to be evaluated for immunodeficiency because immune competent children are unlikely to get the disease after a vaccine. So for that means that we need to know which are the vaccines which are very effective and which are the vaccines which are only moderately effective. The limitations also we need to know. Now, one question, catch-up vaccination. Okay, so catch-up vaccination, that is a very common question in DNB OSCEs. So whenever you are asked about a question, see, I'll just give an example. Imagine you have a 10-year-old unimmunized child now brought with injury. What would you do? Here again, your answer should be what you would do to prevent a tetanus disease because of the present injury and also prevent tetanus in the future. So to prevent tetanus in the present injury, you have to give 10 globes. So this should be clear why you give immunoglobulin. Because when you are giving the vaccine, it takes some time to produce an immune response. So if you have diseases with short incubation period, especially, you need to give the immunoglobulins earlier so that it can take care of the time when the vaccine is going to get effective. So that is why if a child, unimmunized child, gets a TT, which is a tetanus prone injury he is having, In that case, you have to give both Tetclob as well as the TT vaccine. And remember that 1 dose of TT vaccine for him is not going to prevent future tetanuses. So he has to continue his vaccination. So coming to a 10-year-old child who is unimmunized coming for a catch-up vaccine. So you have to give 3 doses of tetanus containing vaccine at 0, 1, and 6 months of age. So that 0 dose can be Tdap or TD. The 1 month and 6 month doses again can be TD or Tdap. Especially the 0 dose, you would prefer it to be Tdap because the child has not received any diphtheria or Asella pertussis before. So regarding the tetanus containing, I hope it is clear. It is 0, 1, 6 followed by a booster 6 months later, and ideally 1 more booster 1 year later. So every vaccine, whenever you have a catch-up vaccine to be written, write each vaccine separately and write what you're going to give. So you're going to write tetanus containing vaccine, schedule 016, booster 1 more after 1 year. Hepatitis B vaccine, 016. MMR vaccine, 2 doses, 1 month apart. Hepatitis A vaccine at 0 and 6. So which are the vaccines you're not going to write? You're not going to write BCG. You're not going to write OPV because the child is 10-year-old. So I hope that is clear. And if you want to write, that is an easier way of writing rather than writing first visit which vaccine to give and second visit which vaccine to give. So you can schedule an immunization schedule like that also. I hope that is clear. I hope I haven't confused you. The infantile pertussis again and how to prevent it. Okay. So if there is a question how to prevent infantile pertussis, then you should understand that pertussis whenever you are giving the DPT vaccine at 6 weeks, that is not going to prevent pertussis in a child who is 2 months of age because the initial doses are only priming doses. You are just stimulating the immune response. Only after the patient has completed the primary series or completed the booster, do they have enough antibodies to protect themselves. So to protect a baby during the initial months, it is important that the mother is vaccinated well so that the baby gets antibodies from the mother. So that is the reason why you are recommending Tdap vaccine for the mother after 28 weeks of gestation. Between 28 to 36 weeks, the sooner the better, so that the baby gets anti-pertussis antibodies from the mother and is protected from pertussis disease, especially during the first 6 months of life. I hope that answers your question. It is also, and there is also a strategy called cocooning strategy where all the adults in the family where a baby is going to be born get vaccinated themselves with the Tdap vaccine so that they don't act as a carrier for the baby. Here also 80% infection is from the household contacts. So then explain the current national immunization schedule. Divya, the basic current national immunization schedule, we all know at birth, we are going to give OPV, the birth dose of hepatitis B. That is the birth dose that you're going to give. Then you have the 6, 10, OPV, BCG and hepatitis B. And then you have the 6, 10 and 14 where you're going to give Pentavac as well as Rotavac. And some of the states, they have also introduced the PCV13, which is given at 6 weeks and 14 weeks. Then at 9 months of age, you are having the MR vaccine, followed by at 1.5 years, that is 16 to 24 months, you have the second dose of measles containing vaccine, which is MR in case of national immunization schedule. Some states give MMR, and you also naturally give the DPT booster as well as OPV. And IPV is now given fractional dose at 6 and 14 weeks. So there is no single dose IM schedule in the 14-week national immunization schedule. So throughout India, every baby is getting 2 doses of IPV, but they are fractional doses and they are given at 6 weeks and 14 weeks of age. Then after 1.5 years, the next vaccine due is 5 years where you give DPT. And at 10 years, now TD has been introduced. So you will give TD at 10 years, followed by TD at 16 years. And after that, you have the decennial TD. In certain states, you have the Japanese encephalitis vaccine, which is recommended to be given as 2 doses at 9 months of age, as well as at 1.5 years. So this is what the current national immunization schedule is. The states where PCV13 has been included in the national schedule, They use the PCV13 at 6 weeks, 14 weeks, and the third dose at 9 months of age. If in ARV, if missed dose, what to do, ma'am? Should I restart from first? No, I think there's a question before that. Okay, if a dog is vaccinated with rabies vaccine, should I vaccinate after dog bite? Definitely. I wouldn't say that because there are certain criteria for you to think like what is the age of the dog, which vaccine it has been given. For the current schedule, whether the whether the dog is vaccinated or not, it is always you follow the anti-rabies schedule that is recommended. In case of the missed second dose of rabies dose, should the schedule be repeated? No. In fact, there are places where they tend to repeat, but that is definitely not recommended. If imagine you are planning to give on 037 and the patient lands on day 7, he has only taken the 0 dose. So you consider the day 7 as the day 3. So you will give the second dose that day. And again, 4 days later, you will give the next dose. And again, day 14 and day 28, depending on IM or ID you are following. So you again need to continue from where you have stopped. So again, one more thing I have to add regarding anti-rabies vaccine. I told you that if the patient has already received the vaccine, immunoglobulin can be given only up to 7 days. But imagine the patient has not received the vaccine, had not received the immunoglobulin, and he had a class 3 bite, and he's coming to you after 1 month and telling you that last month I had a dog bite. I did not take any vaccine. And now somebody told me that the dog died 3 weeks back. What should I do? So here you have to give both vaccine and immunoglobulin because rabies is a disease with a variable incubation period. So if they come without receiving anything, depending on the class of the bite the child had at that time, you need to offer the anti-rabies protection. Is there any recent change by ACVIP on Tdap that it can be repeated? Yes, the ACVIP says that it can be repeated or it may be repeated. They are not telling it should be repeated. It's written it may be repeated. COVID vaccination in children. Right now, COVID vaccination, it's because it's only 16 to 18 years. And India has definitely not allowed the vaccination in children. So we needn't discuss that. Not really recommended, I would say. So is the questions over or somebody wants to ask direct question can ask. I hope I have cleared the doubts that you have asked.
If anyone want to ask questions, please unmute yourself and ask.
Ma'am, what is vaccine hesitancy?
I didn't get the question. I think the question you are asking is what is vaccine hesitancy or the causes of vaccine hesitancy. What was that? It was that. Vaccine hesitancy basically means that you are advising a vaccine and the patient is not taking the vaccine. So vaccine hesitancy can be, it's mainly because of a misinformation that the patient is having, or he has seen an AEFI in someone else and because of that he's scared, or he doesn't believe in our modern system of medicine and so he doesn't believe in vaccine. So there can be multiple reasons why a vaccine hesitant. So vaccine hesitancy definitely otherwise can be asked as a short note because that was relevant, especially when we launched the COVID vaccine, and now when the COVID is spreading very fastly, everyone wants to take the vaccine. As Aditya said in the beginning, that hesitancy has come down. Some religious reasons are also there for vaccine hesitancy. There can be multiple reasons.
In National Immunization Program, why HIB is left, why MMR is left?
Okay, so 2 questions there. Why the HIB vaccine means when you are in an IAP schedule or schedule wherever you are giving a HIB vaccine also at 1.5 years, and in a national schedule, the HIB is given only for 6, 10, 14 weeks. So what we have to understand is that when you are having a HIB, we should always understand that the IAP schedule and the national schedule may differ at certain points, but they are in fact not contradictory schedules. They are complementary schedules. Only thing is that the aim is different. When you're doing a national schedule, you're looking at getting maximum protection with a moderate or minimum expenditure. When you're looking at the IAP schedule, it is an office schedule. You're looking at each individual child and you're more bothered about the child getting protected rather than the community. So that is why there is a difference comes. So why the hip vaccination is recommended only 6, 10, 14? Again, economic reasons and also the epidemiological reason that most of the hip meningitis cases happen in children less than 1 year of age. So that is one reason why it is recommended like that. The next reason is that hip vaccination has excellent herd immunity. So that is again one question. When you have herd immunity, you should know it is not only about polio. We are talking about herd immunity. Your hip and pneumococcal vaccine also had herd immunity. Rather than herd immunity, I would use the term herd effect. Herd effect means when you are vaccinating a small population, the other population is also getting the protective benefit. In case of hip, when you're giving the hip vaccine at 6, 10, 14 at a national level to all the children, the nasopharyngeal carriage of the hip bacteria comes down. And because of that, the hip incidence comes down. So that is exactly the reason why the government is recommending only up to 6, 10, 14. And I think that's an evidence because when we were doing post-graduation many years back, then 96 and all, we used to almost see hip meningitis every at OPD or every admission day. And now we have not seen hip meningitis for last many years. So that herd effect has still been there. The other question was, why is MR recommended at 9 months and not MMR? The answer here is that, again, economic reason, the mumps component is the costliest one. And unfortunately, the mumps component is the one with the least protection effect. So if you ask me, given an option, which vaccine would you take at 9 months? My answer would be there is nothing to choose between MR and MMR at 9 months of age. Because at 9 months, your priority definitely lies with measles. And rubella, you're giving at 9 months because you want to decrease the number of vaccine dropouts. The number of children who take vaccine at 9 months are considerably higher than number of children who take vaccine at 1.5 years. So in order to avoid an epidemiological shift, the MR was introduced at 9 months of age. The aim is different. And rubella is highly effective. Even single dose will be around 98 to 100% effectiveness. So there's nothing to choose between MR at 9 months, but definitely at 1.5 years, MMR needs to be given. And MMR, it's better you repeat the MMR at 5 years of age also. I hope that answers the question.
Then why should in IAP 4 doses?
Sir,
3 doses. MMR 3 doses there at 10 months, 15 months, and at 4 years.
Yeah, because 10 months MR is not available in the private sector. Private sector, what you have, the measles containing vaccine right now, what you have is MMR. So that is why you're recommending MMR at 9 months. And it doesn't harm giving an MMR. And the irony is that the number of children who get measles vaccine, they're usually unvaccinated or partially vaccinated. And the number of children who get mumps after vaccine, in fact, 80% of them are already previously vaccinated. So if you are looking at protection for mumps vaccine, the efficacy comes down at years passed by. And that's the exact reason why MMR is recommended at 5 years.
Thank you, ma'am, for the excellent session. And I think we have given a very difficult topic to ma'am, and ma'am has done total justice to the topic. And I think we have finished the questions.
One question, Ajay, that is, can a COVID positive child receive ARV if there is a dog bite? Yes, here we have absolutely no doubt because your anti-rabies vaccine is always a priority. So now we usually say that 2 weeks interval between COVID vaccine and ARV, even in an adult. When it comes to anti-rabies vaccine, that is a priority. Nothing else comes in between. So whether your patient is COVID positive or negative, go ahead and give the anti-rabies vaccine.
Thank you, ma'am.
I think I've answered the question.
Yes, I think you have covered all the parts of immunization. And it's a vast topic, like ma'am has told initially. But I think this is a brain teaser for everyone to go into more depth of immunization because it's a very important topic for OSCE discussion. And it has been wonderful to start off our OSCE series with Shija ma'am. And thanks for all the support, ma'am.
Thank you so much for the opportunity.
Thank you, Shreja. I was hearing throughout. That's excellent.
Exactly.
Okay, ma'am. Shall we wind up.
Okay. Definitely.
Thank you, ma'am. Bye, ma'am.
Okay.
Good
Good
night.
night.